Dr. Papytcho, you can go ahead.
Thank you very much, Sarah. Good afternoon, all, and thank you for coming to today's discussion. Today we'll be talking about oxygen therapy. In the oxygen therapy series, we'll be talking about high flow nasal cannula and non-invasive ventilation. So this will be a case discussion. With me, I have Dr. Opiri from Nasoko Hospital as co-panelist. I also have Dr. Sipu Kandaba from Nasoko Hospital, another co-panelist. We welcome you all and hope we're gonna have a nice discussion. We encourage you to write down your question in the chat box. And at any time, any one of us will be available to attend to all the questions, and we will make it as a live discussion. Thank you, sir. So today's case, it's Mr. G. It is a 39-year-old male who presents with history of tachypnea and hypoxemia. Part of its management, the use of high flow oxygen therapy and non-invasive positive pressure ventilation. Sarah, can you go up, please? Thank you. So the practice change objective for today's session in the rubric of high flow oxygen therapy is to understand the upper limits and low flow, understand the upper limit of low flow devices, to differentiate between low flow oxygen therapy and high flow oxygen therapy, to understand when to escalate to high flow oxygen therapy, to list the proposed benefit of high flow oxygen therapy, to list possible complications of high flow oxygen therapy, and understand how to up titrate high flow oxygen therapy and how to down titrate high flow oxygen therapy. And when talking about non-invasive pressure ventilation, the practice change objectives will be to list the indication for non-invasive positive pressure ventilation for acute respiratory failure and list proposed benefits of non-invasive positive pressure ventilation, and as well as the complications. As we said in the introduction, today's discussion will be a case of Mr. G, 39-year-old, who present with history of 5 days worsening shortness of breath and dry cough. His breathing is harder when he gets up and walks around. So he has tried to stay in bed and rest. He noticed that his finger and toes are blue when his breathing is worse. I'm sure we've all had such patients during our career, during our waking time, and we'll try and go to on different clinical findings and the history taking of these patients. And then based on this, we'll be able to outline our management. So his past medical history is obese with a BMI of 35, is a diabetes type 2 patient or hypoglycemic. Surgical history, he had an appendectomy when he was age 20. He has non-allergy. On the social history, he works as a house painter. He's a divorced man. He has one son, age 10 years. He doesn't smoke, but he drinks beer on the weekend. So in part of today's discussion, as it was said, there will be high flow oxygen therapy. But before we go further, we will never remind ourselves about personal protective equipment. It's very important to remember wearing PPE every time that we get in contact with a patient who suspect or a confirmed case of COVID. About use of PPE, encourage our participants, when you log in on their website, you can click on this yellow box, and then it will give you more information about doffing, and different type of PPEs that are available on the market and how to use and when to use them. So the practice change objective, as we said, to understand the upper limit of low flow devices and to differentiate between low flow oxygen therapy and high flow oxygen therapy, understand when to escalate high flow oxygen therapy. We've had to use oxygen delivery devices before, and here there's a question that comes: when using the oxygen delivery devices, which one will deliver the highest FiO2? I would like to remind that FiO2 stands for fraction of inspired oxygen. So which one of these devices deliver the highest FiO2? Please feel free to drop your answer on the box, and this will go questions. Sarah, could you please open the poll for us?
The poll is not working, so let's answer in the chat.
Okay, thank you, Sarah, for the update. This participant, you can drop your answer in the chat. Okay, I'm seeing already answers that are coming. And from the answer
And the poll is working now.
Reading. Oh, finally, the poll is working. Thank you, Sarah. Okay, Sarah, you can end the poll. Thank you. Wow. 75% of our participants got it correct. So actually, it's a mask with reservoir bag that will give you the highest FiO2. We'll have more discussion on this in the next few minutes. But as at for now, we'll go further on the discussion and read the case update. And then later on, we'll discuss about different oxygen delivery devices that are used and how they happen to deliver the FiO2 and how much FiO2 each one delivers. So Mr. G, after you go reviewing, you found that he has the following vital signs. His temperature is 38 degrees Celsius. His heart rate is 99. His blood pressure is 107/88 millimeter of mercury. His respiratory rate, 28. His saturation is 90% on face mask with reservoir bag at 15 liters. As we said earlier on the poll question, that reservoir bag was the highest FiO2 delivery devices at maximum limit of 15. Despite him being on this device, we can see that it's poorly saturating and is having signs of what we can say respiratory distress. At this point, we would like the few signs that they still remember when it comes to respiratory distress. How do you say that this patient is in respiratory distress? What are the signs that you say in a patient for you to talk of respiratory distress? Remember, it's only when you know the signs, that's now when you'll be able to make diagnosis and take the correct management. We can drop your answer in the chat box. Wow. I can see the correct answers that are coming in. But as you are dropping your answer, we would like to specify that a patient who's having difficulty in breathing, you also have an increased rate of breathing and is not getting enough oxygen to fill up the demand that the body is needing for as in oxygen consumption. So such patients, they're in what we call respiratory distress. And to come up with diagnosis, you need to realize that your patient is having a respiratory rate which is increased. When talking about respiratory rate, it's important to have in mind that respiratory rate also depends on age. So in the infant or a neonatal or an adult, the rate will differ based on the age. The patient also can have color changes. You can have cyanose lips, fingers, or tip of fingers or nails. Remember that cyanosis can be different to see on the dark skin, whereby it's easy when the patient is light or has a bright color. The skin can be pale or gray, depending on how the patient's skin presents like. Another sign that you can find is grunting. So grunting is a sound that you hear at each time the patient exhales. It simply means that the body is trying to keep air in the lung so that they stay open. That's what the nose of grunting comes out. The other sign that you can find in a patient is nose flaring. So the nose opening and spreading while patient is breathing. It's just showing that there is increased rate of breathing. patient is making so much effort that is using almost all muscles, everything on the body for him to be able to breathe. And something that is very common, it's retraction. The chest skin, the chest will sink in just below the neck and under the breast. And that happens with each breath. Every time the patient breathes, you find that the chest is almost sinking either on top of the neck or in between the ribs. So this means that the body is trying to bring more air into the lungs, using now accessory muscles, everything that the patient have, so that they get enough oxygen. Remember, this patient is in short of oxygen. That is why they're having this distress. The patient can be sweating. They will have a skin that is cool or clammy, and with an increased respiratory rate. There will be also some other noise, wheezing. So the wheezing is a whistle that is at each breath. So the air is passing through a smaller or a tight passage. Also sometimes can reveal patient who's in distress. He will lean forward while sitting to help take a deep breath. So when you have such patients, it's important to know this so that you happen to identify them, patient who's in respiratory distress, and then you take correct management. There's more information about respiratory distress on this same website. When you click the link, it will give you more information. As that for now, we can watch this illustration of a patient in respiratory distress by the below video. I hope the internet is good enough for our participant to watch this video as it's playing. When you look at it closely, you'll find that all the signs that we talk about, they're on this patient. Thank you, Sarah, for the video. So this is a patient who was getting oxygen by non-rebreather face mask, and then it wasn't improving in terms of saturation. So here the question that comes is on how to escalate, and by escalating its management, we would like to know which device will you choose, and I believe everyone will go for a high flow nasal cannula. So now here the question is, how do you deliver the oxygen using the high flow nasal cannula? Is it through a standard cannula, or there's a different type of cannula that you use as a catheter, nasal catheter for delivery of oxygen to such patients? There's a poor running. Your answer will be either be true or false. If it's true, it means it's a standard nasal cannula. If it's false, meaning it's a different type of nasal cannula. I believe all of us we've seen how it would be a straightforward question. Thank you, Sarah. We can end the poll. Wow. We are dealing here with genius. We are getting all the answers correct, as a majority of us understand what it is. Thank you. So we continue for our discussion. At this time, we want to learn more about high flow oxygen therapy. But this, I'll hand it up to Dr. Ndaba, who goes to the high flow oxygen therapy, the principles, and Dr. Ndaba, please take it up.
Thank you so much, Papytcho. And I would like to welcome all our participants, my fellow presenters, the technical team. Yeah, thank you so much for the initial discussion, Papytcho. And I would like to just encourage our participants here to log into our Learning Resource Center for most of this material that we are discussing, including all the videos that are being shown here. So thank you so much. So Sarah, I would like you to play the video as we go into the next phase of this discussion, where we'll be talking more on high flow oxygen therapy. Hi, Sarah. Papytcho, do you have the volume?
Is the audio not working?
No, there's no.
Oh.
If an oxygen device delivers less than the patient's inspiratory flow, then the delivery...
Is it working now?
Okay, can we please start the video?
Start over.
So what is high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets
Sarah,
or
maybe we start
exceeds
from the
their
beginning.
inspiratory
Thank you.
flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC, or even HFOT or HFT, or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high flow humidified oxygen delivery device. Now, like other high flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient. And when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So, should high flow therapy be a replacement to other forms of therapy like non invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive and can tolerate short breaks. Clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high flow oxygen. Of those 104 patients, unfortunately, 27 of them failed. And of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a CPAP effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout. But again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Great, thank you so much. I hope that video was useful to set the grounds for the next session. So this particular session will focus on high flow oxygen therapy. I'm pretty sure that most of us are now familiar with the low flow oxygen devices that we've been using on our patients, more especially the COVID patients. I'm sure we are aware of the nasal prongs, the simple oxygen masks. We've used the non-rebreather masks, the Venturi masks, that have flooded our facilities. So at this particular session, we'll focus on high flow oxygen therapy. And like you've heard from the video, the definition of high flow oxygen therapy really borders on a patient that will require more than the normal inspiratory flow of oxygen, which from the video was clearly defined as, for a patient at rest, the normal inspiratory flow is between 20 and 30 liters per minute. So any patient who requires inspiratory oxygen flow of more than 20 to 30 liters per minute, it means we are administering high flow oxygen therapy. For practical purposes, I know most of our facilities, we have a non-rebreather mask, an oxygen mask with a non-rebreather bag, as the highest sort of oxygen delivery device that can deliver a higher percentage of oxygen to our patients. But on a practical basis, we've been using that as sort of as a limit for us to define a low flow oxygen therapy or low flow oxygen requirements and those that will require higher flows. Meaning that
a quick examination on him, I will be done right back.
So meaning that any patient who requires oxygen therapy beyond a non-rebreather mask, we've been classifying those as patients who require high flow oxygen therapy. So, so the practice change objectives for this particular session will discuss the proposed benefits of high flow oxygen therapy. We'll list some of the possible complications of high flow oxygen therapy, and also understand how to up titrate high flow oxygen therapy, as well as how to down titrate high flow oxygen therapy as well. So when we refer to the patient that we have, so despite our patient receiving oxygen by mask with a reservoir bag, Mr. G continues to have a fast respiratory rate, and his rate currently is now at 36 breaths per minute. His oxygen saturation is falling. It's currently at 88%. And the bedside provider decides to place him on high flow oxygen therapy, meaning that this is a patient now who requires more flow than they would actually take when they are at rest, which is 20 to 30 liters per minute. So what are some of the benefits of high flow oxygen therapy? What benefits do we have or do we get for putting the patients on high flow oxygen therapy? So I'll quickly run through some of them, which may not be very exhaustive, as I urge all of you just to make reference to the Learning Resource Center for a more detailed read-up. So some of the benefits of high flow oxygen therapy include the fact that you would be able to achieve or deliver a higher percentage of oxygen, also called the fraction of inspired oxygen or FiO2, to the patient. You would be able to give a higher percentage of oxygen, and that in turn would improve oxygenation, and your oxygen saturations will be observed to be increasing. So it also offers us an opportunity to escalate for those patients who are not doing so well on the inferior oxygen delivery devices. It offers an opportunity to escalate to higher flows. And by doing that, we are giving the patient an opportunity to increase the oxygenation and reduce their work of breathing, reduce their respiratory rates, and also reduce the incidence of progressing to ventilation or intubation rather. So it also, through high flow oxygen delivery, we provide warm and filtered as well as humidified oxygen. So you will not give the high flow oxygen on its own. This oxygen has to be warmed, humidified, and filtered for the patient to be comfortable. And also we avoid mucosal injury and other forms of airway injury as well. So it also helps to wash out the excess carbon dioxide within the respiratory tract, which we call carbon dioxide dead space. So when you flush out that high flow oxygen into the airway, it also helps to eliminate or to flush out the carbon dioxide that is still stuck in the bronchial tree. High flow oxygen therapy also offers some small positive end expiratory pressure, or what we call small continuous positive airway pressure, which is CPAP, and this has been shown to increase oxygenation as well as improve oxygen saturations as well, because it helps to open up the alveoli, recruit more alveoli so that they can participate in oxygenation, and also it helps to sort of push out the excess fluid, if there's any, in the lungs, especially those patients that have got some airway or pulmonary edema. It also provides that positive pressure, which pushes out that fluid. And by doing so, it provides a more bigger surface for oxygenation, and the SpO2 or oxygen saturations will sort of improve. Yeah, so those are some of the benefits of high oxygen flow that will provide to these patients. Remember, as we follow through the oxygen escalation ladder, you start with the most inferior oxygen delivery devices, and then you monitor the patient. If this patient is not improving, as you go up the ladder, you reach this point where you may have to put the patient on high flow oxygen therapy. And the most common device that we have right now, which can provide this high flow oxygen therapy, is a high flow nasal cannulas, which I'm sure now most of the facilities have this device that we've been using to provide high flow oxygen therapy. So if your patient doesn't do so well on the high flow oxygen therapy, this is a critically ill patient, and you may now resort to non-invasive positive pressure ventilation, which we are going to discuss later on. So remember, we are on a journey. If the patient doesn't improve, we escalate the level of care. And at that point, if they don't improve, we escalate to move to the next one. So at this particular point, our patient requires high flow oxygen therapy, and we are going to use a high flow nasal cannula that we have in our facilities to provide, to optimize oxygenation. So those are some of the benefits of high flow oxygen therapy. Then I'll move on to some of the complications of high flow oxygen therapy. So some of the known or recognized complications of high flow oxygen therapy would include, because of the increased flow of oxygen, certain patients may develop abdominal distension because of that sort of positive pressure that is being pumped through the airway, through the oral cavity. If the flow is extremely high, cases of barotrauma may actually be experienced by the patient, especially if the patient is receiving non-humidified oxygen, which is not warm and dry. The patient is likely to suffer some degree of airway injury, and other related complications. Incidences of subcutaneous emphysema, where the air leaks out into the subcutaneous tissue, as well as spontaneous pneumothorax, have been reported in certain patients, because high flow oxygen of up to 60 liters per minute for a prolonged period of time may cause subcutaneous emphysema or a spontaneous pneumothorax. So those are just briefly some of the complications that may arise as a result of high flow oxygen therapy, and we need to be wary of these complications and avoid them from happening. So Sarah, we can just move the slides upwards so that our participants can appreciate one of the complications. So this chest X-ray is just there to sort of give more information on one of the other common complications of high flow oxygen therapy, which is subcutaneous emphysema. There's extravasation of air because of that high flow oxygen that is being bombarded into the patient's airway. Some air may actually leak out into the subcutaneous tissue and cause what is called subcutaneous emphysema. And it may also, in the long term, cause a spontaneous pneumothorax, where air leaks out into the pleural cavity. Yeah, so those are some of the complications that may arise. But again, feel free to actually log into the Learning Resource Center to access these materials. We can go up, Sarah. So the next question is, what are the 3 parameters that must be set on high flow oxygen therapy device by the bedside provider? So that patient, the provider has decided to put that patient on high flow oxygen therapy. And so for those of you that have used or that have had access to a high flow oxygen device or a high flow nasal cannula that are being used in most facilities currently, you would agree with me that the 3 parameters that you can adjust to improve oxygenation will include the flow rate. Okay, the flow rate may range between 5 and 60 liters per minute. Usually and typically we would start from 20 and then we start titrating upwards whilst looking at the general condition of the patient and also looking at the response in terms of work of breathing, in terms of the oxygen saturation. And if they are not improving, we increase in small increments of 5 to 10 whilst looking at the response as well. So you have the flow rate. The next very important parameter that you can adjust is the FiO2, which is the fraction of inspired oxygen or the percentage of oxygen available for the patient. So this will range from 21 to 100%. So you can adjust between those two parameters. And then the last one is your temperature. Remember, you need to humidify. Humidification is an important part of this process. And so you will need to regulate the temperature of the distilled water that you are using to humidify the air that you are giving the patient. And so you regulate that temperature. Most clinicians rather would prefer to start at 36 or 37 degrees Celsius, consistent with the body temperature. So those are the 3 parameters, very simple parameters, and these devices are very, very easy to use. And those that have these devices in their facilities, they can testify that they've shown really a lot of benefits because you are able to escalate from the inferior oxygen delivery devices to a higher level of oxygen delivery device and prevent a patient from deteriorating. Yeah, so those are the 3 main parameters that you can adjust. And so, Sarah, moving on, I think the next session, we have a video that would just sort of summarize some of the things that we have discussed. And this will specifically talk about the high flow device. So kindly play the video for us. Then we'll move on to the next session.
In this video, we talked a little bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy. We already discussed that high flow therapy is not a replacement for non-invasive ventilation because it is not capable of providing the same level of ventilatory support like NIV. In high flow therapy, for example, there is no inspiratory pressure setting, no PEEP or CPAP setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only 2 main controls on high flow therapy are FiO2 and flow. This is typically adjusted to maintain adequate oxygenation. The FiO2 can be set from a level of 21% to a level of 100%. Usually, patients in acute respiratory distress who are on high flow may initially require a high level of FiO2 to maintain an appropriate saturation. Next is the flow setting. The flow is usually set to try to meet or exceed the patient's inspiratory flow demand. This is challenging because it's difficult to determine what the patient's inspiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory distress, the typical inspiratory flow of an adult is around 20 to 30 liters per minute. But for patients in distress, their flow demand will likely be higher. So clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need. So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40 liters per minute. On other devices like the Airvo 2, they can go as high as 60 liters per minute, and still others can go higher. So these two settings, the flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress. If the respiratory rate or the CO2 on the arterial blood gas cannot be corrected or stabilized despite a relatively high flow rate setting, you may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient. But whatever you do, do not delay escalation if the patient does not improve with high flow oxygen. Okay, now remember, because there are no patient alarms and data monitoring is not available on high flow oxygen devices, regular patient monitoring is critical. There is one more control in high flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature setting is debatable, and there currently exists no temperature standard. Some suggest to start at 37 degrees Celsius, others suggest start lower. But the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance. Which patients should high flow therapy be placed on? It's still a bit unclear, but we tend to see good outcomes in patients with what we call de novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia but in the absence of chronic lung disease such as COPD. We also do not include the kind of respiratory failure that occurs in the immediate postoperative or post-extubation period. Remember, high flow therapy can deliver a high FiO2 at a high flow rate, so we anticipate it to be beneficial for hypoxemic patients. However, if a patient presents with acute hypercapnic respiratory failure, which is exhibited by an abnormally high CO2 and a corresponding abnormally low pH, then clinicians may want to consider an alternative form of intervention, such as NIV. Well, what about you? How have you seen high flow therapy used? Leave your comments below. I would love to read some of your responses.
Yeah, thank you so much. At this particular moment, I would hand over to Dr. Piri to continue the next set of discussions. Dr. Piri.
Good afternoon, everyone. Thank you so much, Dr. Papytcho and Dr. Ndaba. I'm briefly going to talk about the indications for high flow oxygen therapy in general, but today our discussion will be biased towards the high flow nasal catheter. So the high flow nasal catheter, I think we have heard in the previous two segments of this discussion, this is an oxygen delivery device, a high flow oxygen delivery device that is particularly useful in cases of severe hypoxemia in the absence of hypercapnia. So you're talking about severe hypoxemia with non-hypercapnic respiratory failure. So there are a number of conditions where the use of these devices are beneficial. Before I go into the particular conditions, I just want to sum up or give direction what we should all be thinking when we're talking about the use of these devices. First of all, these devices have been used, they're relatively new, So they've only come on the scene since the 1990s, but they're a game changer for conditions presenting with severe hypoxemia. So here you want to administer high gas flow rates, and these gas flow rates, they need to exceed the patient's peak inspiratory flow. I think we've been told in the previous videos that for an adult, typically this is about 20 to 30 liters per minute. However, I want to introduce to you a mnemonic called high flow. That is HIFLOW. So the high flow mnemonic, it really tells us what exactly these high flow delivery devices do, particularly the high flow nasal catheter. So the H in high flow stands for heated and humidified. So the gas, the oxygen which you're delivering will be heated and it will be humidified, just as the previous speakers have mentioned. The I is talking about the inspiratory demand. So the oxygen that is being delivered, it meets the actual demand, inspiratory demand that the patient has. So you're delivering very high flow rates. Next, the F stands for the functional residual capacity. So what the high flow nasal catheter, the HFNC, what it does is that it increases the functional residual capacity. And we all know that the FRC, the functional residual capacity, this is the oxygen tank or the oxygen reservoir that we have in our body. Remember, our tanks sort of work as a tank. Next, the L in the high flow mnemonic stands for lightweight. So if you compare the weight of the high flow nasal catheter, the HFNC, compared to the weight of a CPAP mask or a CPAP hood, patients are more compliant to the use of the HFNC, the high flow nasal catheter, as opposed to the CPAP. So patients initially may not cooperate, but with HFNC, because of the lightweight, they're more likely to be compliant. The O talks about oxygen dilution, really. So when you talk about oxygen dilution, if you're using the conventional, the old nasal, the low flow nasal cannula, you have the theory of oxygen dilution. You may be delivering high flow rates of oxygen, but there's significant dilution which comes in, especially if your patient is mouth breathing. But with the high flow nasal catheter, because of the flow rates which are being delivered, you have reduced or minimized oxygen dilution. While the W in the mnemonic stands for the washout of the pharyngeal dead space. We all know that we have dead space in the upper airways. So there's mixed reduced. So you actually have washout of your pharyngeal dead space. So with that background, I'm going to talk about conditions where the use of the high flow nasal catheter is indicated. So one, you'll find that I did mention that you're talking about severe hypoxemia, so low levels of oxygen, but you don't want to use this delivery device if your patient also has a corresponding hypercapnia. So one, you want to use this in severe hypoxemic respiratory failure without hypercapnia. Typically, in this situation that we're in, COVID pneumonia is a good example. Community-acquired pneumonia, this device can also be used. There are other instances when we use the high-flow nasal catheter. I'll give an example of the operative or perioperative period. Before a patient is induced, for those people who have worked in a theater setting, before a patient is intubated, you'd want to support the breathing of the patient. So as you are pre-oxygenating or delivering oxygen, you may use your high flow nasal catheter. After a patient is extubated, whether it's in theater or whether it's in an ICU setting, it's in a resus or emergency care setting, or any critical care setting, high flow nasal catheter has been shown in studies to increase the support, the oxygenation post-extubation. During certain procedures, you could be in an outpatient suite. Maybe it's a bronchoscopy unit or a bronchoscopy suite. As you are removing a foreign body, for instance, the high flow nasal catheter, This is an oxygen delivery device that can be used to oxygenate a patient. So these are patients who you are not intubating for particular reasons. So high flow nasal catheter can be used. Post-extubation support, I think I've talked about this. Post-operative respiratory failure, a patient has had surgery and there is severe hypoxemia without hypercapnia, any respiratory failure. These devices have been shown to be useful. In an ICU or a resus setting, a patient who is being weaned off tracheostomy, high flow nasal catheter has also been shown to be particularly useful. So this is when you're weaning via tracheostomy. However, there are other medical conditions in which the HFNC, your high flow nasal catheter, can be used. So we're talking about conditions such as acute pulmonary edema. There are also patients who have signed a consent not to be resuscitated should their condition be critical. So you do not resuscitate patients or patients who have elected not to be intubated. So a high flow nasal catheter is still a form of active oxygen management, where it's still a form of passive oxygen management, where active intubation and resuscitation has been declined. In pediatrics, there's been a growing trend and more studies in the pediatric population where the high flow nasal catheter can be employed. So you find that children, infants presenting with bronchiolitis, for instance, would have been shown to benefit from high flow nasal catheter. Babies presenting with croup. There's been an increase of use in asthma as well, in pneumonia, also during transportation of these critically ill children, and also post-extubation. So those are some of the indications in the pediatric population. Sarah, can you please scroll downwards? Okay, so at this point, I just want to encourage everyone who is participating in this classroom. If you go to the learning resource centers, there are 4 links which talk about the high flow nasal catheter. These links will take you to various websites and the various studies which have been done. So I encourage everyone to log into the Resource Learning Center and get more information about what we have just discussed. Sarah, can you scroll downwards? Okay, Sarah, I'm just going to ask you to zoom out a little. I don't seem to have the clarity of the screen. Please just zoom out. Thank you. Okay, so at this point, I'm going to ask Sarah to have a poll. There is a question which I'll invite all the participants to take part in. So the question is, which of the following is incorrect regarding the parameters that can be set by healthcare workers when delivering high flow oxygen therapy? So which is incorrect? There are 5 options there. So please, as a poll, submit which one is incorrect. Okay. Sarah, we can close the poll in the next 10 seconds. Okay. Sarah, you can close the poll. Okay. Okay, so here we've got the poll results. So it's quite a mixed picture. I think that majority, 46%, said the incorrect answer is that.
Excuse me, Hope. J.Lo and Ben.
So 46% of the participants of our audience have said that providers can directly measure the flow at which a patient is breathing and match the inspiratory flow demand on the high flow device. So 46% say this is the incorrect answer. And for sure, you find that when you're using your high flow oxygen delivery device, the other answers are correct. Providers can use a respiratory rate to estimate the initial flow. The average inspiratory flow rate for an adult really is 20 to 30 liters. I think this was mentioned in the 2 videos. The flow rate, which is set, should attempt to meet or exceed the inspiratory flow demand. This is true because if you are below the demand, the device becomes a low flow device. And then lastly, the other answer, the inspiratory flow demand increases during respiratory distress. We know that this is true. So patients with a COVID pneumonia, for instance, the inspiratory flow rates can peak up to 5 times the normal to about 100 liters per minute. So sure, 46% were accurate. Thank you. Sarah, can you please scroll downwards? Okay, we seem to have another question as well. This question is, which of the following scenarios would providers need to escalate care from high flow oxygen therapy would you need to escalate care? Would you need to go to a higher modality from your high flow oxygen therapy? So please, participants, feel free to pick an answer and submit. I'll give us 30 seconds to respond to this poll. Okay, thank you, Sarah. Can we see the results of the poll? Wow, the questions are very hard, but well done to everyone. So all of the above scenarios, you would need to escalate care. So just to go through, if your respiratory rate is not improving, if the partial pressure of carbon dioxide remains elevated, if your saturations are not improving, and if the partial pressure of arterial oxygen does not correct or stabilize despite this therapy, you may consider escalating care. So well done to everyone for giving us, for getting this particular question correct. Okay, we go back to our main discussion. Sarah, can you please scroll downwards? Okay, lastly, we're going to talk about the ROX index or the ROX index and what it is, how it can help us as clinicians in the clinical environment, especially in the context of COVID-19. So the ROX index is a recently devised tool which can be used to assess or to predict how a patient on high flow nasal cannula, whether they would fail and they'll need escalation or whether they're doing well. So there is a link on the Learning Resource Center, which you can use. You type in the values. There are 3 parameters. The 3 parameters which are inputted, and then there's a score result which will tell you, it will predict the incidence or the possibility of failure. So what this ROX or the ROX index does is that you need to assess the patient 2 hours, 6 hours, and 12 hours after placing them on high flow nasal catheter. What you actually be monitoring is the saturations of the patient. So the SpO2 is going to be monitored. You're going to input or monitor the FiO2 that the patient is on. And lastly, you're also going to monitor the respiratory rate. So these are 3 basic parameters that can be monitored on the bedside. And then once inputted into the ROX, I think Sarah has been kind enough to share a link. Once you input this, it will assess or it will predict which patients are likely to do well and those who won't. So the link has been posted in the chat box by Sarah. We also have a range. You may perform your ROX score And then you have a range of patients who are indeterminate, or they're really in a gray zone. You don't know whether they'll deteriorate or maybe they'll improve. So for these patients, you want to reassess them 2 hours later. So the indeterminate range is about 3.85 to 4.8. So for these patients, you want to repeat this. So this is very useful clinically, and it can be done on the bedside. So Sarah, can you please scroll downwards? We just get an update on how Mr. G is doing. Okay, so a review of Mr. G finds that Mr. G has remained on high flow oxygen therapy, and these are the current settings. His temperature is now 37 degrees Celsius. He's on FiO2, which is the fraction of inspired oxygen of 100%. He's on high flow. He's really approaching the maximum of his device. So the flow rates are 60 liters per minute. And after 2 days of initial improvement, his SpO2 now drops, is now at 90%, and he's more tachypnic than before. The respiratory rate has gone up to 35 breaths per minute. He looks fatigued, and his arterial blood gas shows that the pH is 7.27, the partial pressure of carbon dioxide is 58, the partial pressure of oxygen is 60. And on the bedside, the doctors who are attending to him, because they're very good doctors, they're concerned that he's not doing well. So now the team is thinking, should we escalate his therapy? Should we move on to non-invasive positive pressure ventilation? So that is where we are with Mr. G. If you look at this clinical picture, this is in keeping with most of the COVID pneumonia patients that we're seeing in our facilities. But how do you put a patient on NIV? It's one thing to order for NIV, but how do you actually deliver it? So in the next, at this juncture, I'll just ask Dr. Papytcho to invite us for the breakout sessions where we discuss more about these aspects. Dr. Papytcho, please take over.
Thank you very much, Dr. Hope. Thank you very much, Dr. Ndaba, for the wonderful discussion. The team of experts reviewing the patient is everyone, all the participants plus the co-panelists. So we want to see how we're gonna put our patient on a non-invasive positive pressure ventilation. So at this time, we're gonna learn the non-invasive breakouts, non-invasive positive pressure ventilation. We'll learn it into 3 different groups. So we'll be broken down into 3 groups. Each group will have a group leader, and then more directive for learning will be given by the leader in that group. So these are the rules and regulations for the breakout session. So each room will have a co-chair or a chair. Once in the breakout room, please elect a spokesperson. So let it be spontaneous. Someone can just volunteer to be a spokesperson. Once we return to the main class, the spokesperson, all they will do is to give the summary of the discussion from each group, and then there will be a whiteboard that will be provided by Sarah, and then so that we'll be able to learn what the others they also discuss in their different group, and then we'll continue and end up our class from there. Please, Sarah, can you break into rooms?
Thank you, everyone. Now you will be just receiving the request on your screen, and then you can just join the breakout room. Thank you.
All right. So for you to use your C-circuit, you need to supply what we call 1 tidal volume to dilute the
Sorry
expired
to
gas.
interrupt you. The people are joining back, and the breakout room has been finished. Thank you, and so sorry to interrupt you in between.
No problem. Dr. Tumba, your tidal volume is about 6 mils per kg. So you need to calculate that.
Okay, thank you.
Thank you very much. Thank you very much, everyone. I believe that the discussion in the breakout room was so exciting. I could see in Dr. Ops, they were still discussing. The interest of time, we're gonna ask Sarah to start for us the whiteboard. And room one will present first. In room one, we discussed indication and contraindication, as well as complication of non-invasive positive pressure ventilation. And our spokesperson is Chilala. She will present on our behalf.
Good afternoon. Okay. We were discussing on non-invasive positive pressure ventilation in room one. And we said non-invasive positive pressure ventilation is done, or is oxygenation done outside the body. Then the indications, number one, anesthesia related. During extubation, you can use non-invasive post-pressure ventilation and in ICU. The other indication is in pulmonary disease. An example, you can use it in pneumonia or in asthma. You can also use non-invasive positive pressure ventilation in congestive cardiac failure. Then on the contraindications, we looked at the absolute and the relative. In absolute, one of the examples of absolute contraindication was cardiac arrest. You can't use it in cardiac arrest. And then relative contraindications examples were in a trauma patient, in a mentally disturbed patient, you can't use. Then example of complications, it causes abdominal distension, it causes emphysema, it can cause pneumothorax, it can also cause pressure sores on the nose. Briefly, this is what we looked at. Maybe the group members can add or subtract. Thank you.
Thank you very much, Chilala. Basically, you've spoken almost what we said. And then I think we'll give it up to room two to continue with the feedback of the discussion.
Thank you so much. So group two, we just covered the basics of non-invasive positive pressure ventilation. And then we also went further to discuss the differences between CPAP as well as BiPAP. Yeah, so to lead this session, I'll invite Luyando, my co-presenter for this breakout session, to just summarize some of the points from our group. Luyando.
Okay, I'll just quickly run through. So on the part of CPAP and BiPAP, we looked at the parameters that are put in consideration. So we looked at the PERP and FiO2. That is what we usually, those are the parameters that we put in consideration. And then on the BiPAP parts, I really didn't get it clearly. I then went on to look at the benefits. Okay, I don't know, maybe you might talk about the BiPAP on the parameters that we consider.
Okay, okay, so you can talk about the benefits, then I can just briefly also just add on to your points.
Okay, the benefits that I took note was to eliminate the excess carbon dioxide from the respiratory tract, and also to reduce the work of breathing. Yes.
Okay. All right. Thank you so much for that discussion. Just to add on to what Luyando has presented. So we discussed the non-invasive positive pressure ventilation as opposed to invasive ventilation, where we said invasive there are two types of ventilation. We have invasive ventilation, where the patient is intubated and mechanically ventilated. And then you have the non-invasive ventilation. In this case, we are talking about non-invasive positive pressure ventilation, where the patient is not intubated. Instead, they have a tight-fitting mask that fits on the patient very well with straps around their head. And then the mask is connected to a breathing circuit. And then you also need a ventilator where you adjust parameters and the high flow or high pressure oxygen source, which can be a cylinder or pipeline oxygen. So then we now zeroed in on non-invasive positive pressure ventilation, which is what we are discussing now. And then we said the two basic modes of non-invasive pressure ventilation, like Leandro has said, is CPAP. And then we said in CPAP, we have two important parameters that you set. One of them is the fraction of inspired oxygen, and the second one is the PEEP, which is the PEEP, the positive end expiratory pressure. Then the other type is the BiPAP. Okay, so BiPAP, which is bi-level positive airway pressure. This one, in addition to the parameters you set for CPAP, you add the second pressure. So you have two pressures. So you have the pressure support, or the pressure added during the inspiratory breath. And then you have the PEEP, the PEEP, as well as the FiO2. So you have three parameters to adjust when you are in the BiPAP mode. So these are the two basic modes that you have under a non-invasive positive pressure ventilation. Then we said that the importance of non-invasive positive pressure ventilation is that it improves oxygenation. It also helps to eliminate carbon dioxide, like Leandro has said. It helps to reduce the work of breathing, and also it helps to push out the excess fluid in the lungs in case of those patients with pulmonary edema. So I think this is just to summarize and to add on to what Leandro has said. Thank you so much. I'll hand it over to group 3.
Thank you for that. Okay, so in room 3, we were discussing high flow oxygen delivery devices. I'll invite our rapporteur who took notes to just briefly go through what was discussed. Group 3.
All right, thank you so much for the opportunity. So we were discussing high flow oxygen devices. So we defined the high flow oxygen device as any device that can meet or exceed the demand of oxygen of an individual. So we said the individual oxygen demand in a standard adult, the physiological adult 72 kg, is about 20 to 30 liters per hour. So any device that can meet this demand or exceed it is considered a high flow oxygen device. So examples of high flow oxygen devices include, and are not restricted, but include the following. We have the non-breather mask with a reservoir bag. And we also have the Venturi masks. So for Venturi masks, they're usually color coded. So we have a Venturi mask with a yellow color, a blue color, and other colors as well. So these Venturi masks deliver a fixed amount of oxygen, and the FiO2 that is delivered is dependent on the FiO2 that is keyed in. So we also have other masks, other devices such as a transtracheal catheter. A transtracheal catheter can deliver up to 4 liters per minute with a dialed-in FiO2. Then we also have the aerosol masks. So the aerosol masks usually, it's basically what we usually refer to as the nebulizing masks, which are common in a research setting where you usually put a nebulizer that is either salbutamol, adrenaline, or Montelukast in the nebulizing bag to more or less dilate the respiratory tree.
Then we also looked at a tracheostomy collar. So a tracheostomy collar, in comparison to other devices, can deliver about 8 to 10 liters with a varying FiO2 depending on the amount that was hit in. So when you look at the tracheostomy collar, this basically requires surgical intervention in setting up, as it is an invasive procedure anyway. Then we also have the T-piece. From the T-piece can deliver an FiO2 that is between 60 to 100% O2. And we also have the C-circuit and the H humidity and the C-circuit rather in the escalating manner that is. Then we also talked about CPAP and BiPAP, which I feel has been explained also by the preceding group. Thank you so much for the opportunity. I'll leave it for my group to further add or subtract any other details that I might have left out.
Thank you very much. I believe, Dr. Ock, you have to add up something. You are the group leader. It's all said.
Okay, thank you for that. I was muted. Lucky, I think Lucky put it up in, I think Lucky mentioned everything. Dr. Shumba has just reminded us. We also discussed the high humidity face tent. And then one other cardinal thing, that the non-rebreather mask as well. These are commonly used. One thing to mention is the C-circuit, the Maposon C, we were reminded is just an ambu bag with a flexible reservoir bag. The configuration is the same. So that is what we discussed in room 3. Thank you.
Thank you, Dr. Ock. And thank you very much for the wonderful discussion and active participation for everyone in different rooms. At this point, Dr. Nva, will you give us the case update? What is Mr. G doing after you put him on the NIPPV?
Yes, thank you, Papytcho. Sarah, can we get back to the main screen? So as we wind up today's session, let's look at how far we've gone with Mr. G. So Mr. G is currently placed on a non-invasive positive pressure ventilation mode. He's been there for an hour with a pressure support of 15 and a PEEP of 5. His fraction of inspired oxygen is at 100%. So on examination minutes, he appears fatigued. He's slumped over in the bed and arouses only when you shake him. So you can see already from this that our patient is critically ill. He's deteriorated all the way through the different oxygen delivery devices. We started with the lowest form of oxygen delivery device. We went to high flow oxygen therapy, and now we are at non-invasive positive pressure ventilation. And still our patient is still not doing very well. So what is the appropriate next step in Mr. G's care? I'm not sure whether this has a poll or it's just an open-ended question. Papytcho, does this have a poll?
There's just an open-ended question you can make.
Okay, so looking at the current condition of our patient, the respiratory rate is still very high. He's exhausted. His levels of conscious Glasgow Coma scale is going down, and we are at the highest level of non-invasive oxygen support. And like we had mentioned earlier on, is that now we'll move to the last resort of oxygen delivery systems, which is the invasive modality, because at this point, we haven't achieved stable parameters despite escalating care up to this level. So this is a patient who would benefit from invasive ventilation. Invasive ventilation means that we need to intubate these patients and put them on a mechanical ventilator. Because failure to do that, this is the patient that we are likely to lose, because they failed to sustain on the different interventions that we've instituted. So this is a patient that may benefit from intubation and invasive mechanical ventilation, which is outside the scope of this session. Yeah, so again, I would like to remind our participants that all these resources are there when you log into the Learning Resource Center. Please find time, log in, and then revise this session at your own time. So thank you so much. I would like to hand it over to my co-panelists for their final remarks before we hand it over to Assist to conclude. Thank you so much.
Thank you, Dr. Ndaba. Dr. Open, final comments as we are concluding.
Okay, thank you, everyone. I think what I just want to mention is that in delivery devices, the only limitation is the resources that you have and the access, what access to high flows of oxygen you have. So if you are in a resource austere or a resource limited setting, the options that you have may be limited to what is currently available. But where resources are unlimited, you can escalate all through the ladder from your basic nasal prongs all the way up to intubation. However, in this pandemic, we are sharing resources against a huge number of patients who need oxygen. So escalation has to be titrated, not only in a vertical manner, but horizontally to share amongst patients. So that is the limitation that we have. Thank you.
Thank you very much, Dr. Thank you, Dr. Ndaba. In summary, is to say thank you to our participants for joining us. And then we encourage them to go on the website for them to get more information. Discussion continues. At any time, you can contact any of the facilitator or co-panelists for any discussion or any question that you might need to know about oxygen delivery devices. Sarah, please, you can take it up and close our class for today.
Great, thank you, Dr. Papytcho and Dr. Hope and Dr. Sapuka for that excellent session. It was very informative. So just to close this out, the Learning Resource Center, where this presentation was and where all of the recordings and resources that you saw today, is a free resource. So please go utilize that, create a free account, and you're able to access everything for free. All of the links to the LRC and to the session recording and to all the other resources will be shared via email after the session. And then I just posted a link to a certificate of participation in the chat. So if you would like a certificate of attendance or participation, you can go ahead and fill out that short survey, and then a certificate will be emailed to you. If you would like to join our WhatsApp group, we would love to have you. You can scan this QR code to join us or message the number on the screen. And then finally, please join us for our next session on August 19th. We'll be talking about defining ARDS with our panelists. And if you have any questions, feel free to email echo@assistinternational.org. So thank you to our panelists for your time today, to Echo, Project Echo for your assistance and assist, and to Stanford University. Have a great rest of your day, everyone. See you next time.
Bye-bye.
Thank
See you
you.
next month.